Hello, friends. A very good evening to all of you. I would request someone to please confirm if my screen is visible and if I'm audible. Is my screen visible and am I audible? Yes, good evening, Aman, Kratika, Avinash, Dr. Live. Okay, so Uh, friends, in the next 60 minutes or so, we will be discussing some very important topics from pediatrics for your upcoming exams. I know the INI-CET and the FMG exams also round the corner. We'll be discussing. So, this will in short be a rapid revision of the entire pediatrics for you. So, we'll be touching upon important topics, important must know areas which you cannot afford to miss before your exams. Okay. So this is going to be an interactive session and I would want the answers of all the questions from you. Okay. So let's begin. So moving to our first question. So which of the following is the best way to assess response to ventilation during neonatal resuscitation? Is it chest rise? Is it improvement in heart rate, change in color, or respiratory rate assessment? Yes, waiting for your answers. So Nagesh says B, Aman Modi A, Siddiq says HR, Mohammad Rafiq B. So most of you are answering B. And yes, that is correct. So improvement in heart rate is the best way to assess adequate response to ventilation during neonatal resuscitation. Okay. So chest rise tells you that yes, air entry is happening. Change in color is going to take time. Respiratory assessment, rate assessment is also not going to give you much idea about whether you know your positive pressure ventilation that you're giving is being effectively delivered or not. So improvement in heart rate is the best answer to this question. So now what is important, friends, is not just going through the previous year's questions, but to also know about that topic, okay, and in and around that topic, because that topic in general is going to remain important for your upcoming exams, okay. So a little bit about it. So the single most important step in neonatal resuscitation, what is it? We know it is positive pressure ventilation. Okay. The positive pressure ventilation is the single most important step in neonatal resuscitation. The rate at which positive pressure ventilation is to be given. Yes. What do you think the rate? So each of what we are discussing can come as a separate question, can come in case scenario based questions. Okay. So this topic remains very, very important. So the rate at which positive pressure ventilation should be given. So friends, I'm not asking the ratio. Just, try to see what the question is asking. It is asking a rate, not a ratio. So it cannot be a ratio, cannot be an answer here. So the rate of positive pressure ventilation, we know the normal respiratory rate of a newborn is how much? 40 to 60 breaths per minute. Okay. So the rate at which positive pressure ventilation is to be delivered is around 40 to 60 breaths per minute. Now, the pressure required to deliver each breath. For the first breath, the lungs are totally collapsed. So you need larger pressure. So you need a pressure of around 30 to 40 centimeters of water to deliver the first breath. And once your lungs have opened up, you need a pressure of around 15 to 20 centimeters of water. Okay, right? What else? So you can get an image-based question like this. So what do you think is this, friends? So this you can make out, I'm sure. Yes. What is this? Tell me. What do you see in this picture? Yes, waiting for your reply. Okay, Akansha says Ambu, Himanshi, okay, Alia, Alagu, Patel, Avinash. Very good. So basically, to be more precise, it is a self-inflating bag and a mask. Okay, so this device that you see, it is a self-inflating bag. Why do you call it self-inflating? So when you squeeze that bag, you release it, it gets inflated on its own, irrespective of whether you connect it to some oxygen or some gas or not. Okay, so if it is a self-inflating bag and a mask, and it has got oxygen tubings. You can see this oxygen tubings, and there is this reservoir. Can you appreciate this bag like thing? So this is a reservoir. Okay, so it is a self-inflating bag and a mask and with oxygen tubing and reservoir to deliver positive pressure ventilation. Okay, so we need to know that. What is the absolute contraindication of bag and mask ventilation? Very, very important question asked n number of times. Must know. So what do you think, friends, is the absolute contraindication of bag and mask ventilation? Yes? Anyone? Very good. Very good, Himanshi, Mohammad Rafiq, Rohit, Jack, Kirti. I'm really impressed. Okay. So most of you are answering it correctly. Yogi, Monica, Kartika, Kung, Shankar. Very good. So absolute contraindication is CDH or congenital diaphragmatic hernia. And if it is a known or suspected case of CDH, then bag and mask ventilation may worsen the condition instead of improving it, right? So now coming to the ratio. What is the ratio recommended between chest compressions and positive pressure ventilation? Yes. Now here I'm asking a ratio, and this again, friends, has come multiple times in various questions. So you must know it. What is the ratio of chest compression and positive pressure ventilation? So this is 3:1 in neonatal resuscitation, right? So just a moment, please. So the ratio of chest compression and positive pressure ventilation is 3:1. Right. So all of you are right. Very, very good. So the order in which suction of airways is done. So suppose you get a case scenario where a newborn is getting resuscitated and you see a lot of secretions, okay, in the oropharyngeal area of the newborn. Now, how do you suction the airway of this baby? So that has also come in the INI-CET pattern question previously. So remember, the order of suction is mouth followed by nose, right? So remember, M comes first, N comes after that. So M followed by N, right? So it is mouth followed by nose, if at all suction is required. Okay. What is the recommended temperature of delivery room? So it is 25 degrees Celsius. What is the dose of injection adrenaline in neonatal resuscitation? Right? What is it? The dose of injection adrenaline. So very few drugs you need to remember the dose in pediatrics. Injection adrenaline in neonatal resuscitation is one of them. So it is basically 0.1 ml per kg of 1 in 10,000 adrenaline, okay, per dose. Right? So the concentration of adrenaline used in neonatal resuscitation is 1 in 10,000, right? Or in other words, you can also write it as 0.01 mg per kg per dose of adrenaline. Okay, so in ml per kg, it will be 0.1 ml per kg of 1 in 10,000 adrenaline. In mg per kg, is going to be 0.01 mg per kg per dose of adrenaline, right? So read each option very, very carefully before answering. So this is an example of how, you have to read each topic in detail, each of the important topics which have been, so in this, basically in this session, I have conglomerated questions from previous year's questions. So to cover the entirely important topics from pediatrics that are a must know and you cannot afford to miss them before your exams, right? So moving ahead to the next question. Which of the following will not be seen in hemolytic disease of newborn due to RH incompatibility, right? So again, hemolytic disease of newborn, RH incompatibility, very, very important topics, must know areas for your exam. So which of the following will not be seen? Always, read the question very, very carefully so as not to miss it, right? So the options are A, raised unconjugated bilirubin, B, raised stool stercobilin, C, raised urobilin, and D, increased urine bilirubin. So Akansha, Kajal, Abdullah, Shubham, Madhumita, right? Alagu, Akansha. So most of you are answering it correctly. So the correct answer to this would be increased urine bilirubin. Why so? Let us see. So for that, your concept needs to be very clear what happens actually in RH incompatibility. So, in RH incompatibility, what is happening? The fetus is RH positive, the mother is RH negative, right? So in the first pregnancy, mother is not having any pre-existing anti-D antibodies, so there is no problem. Now, what happens in the subsequent pregnancies once the mother is sensitized? In the next pregnancy, what happens? There is rapid production of the IgG anti-D by the mother, anti-RH antibodies, right? So what will happen? The fetal RBCs will get hemolyzed due to those antibodies. And because of excessive hemolysis in the fetus, you are going to see what all things? You'll get anemia, you will get jaundice, which will be predominantly unconjugated hyperbilirubinemia, right? So you will get unconjugated or hemolytic anemia, hemolytic jaundice, unconjugated hyperbilirubinemia. Now, a little bit about the physiology of bilirubin. We all know what happens, the RBCs heme and then heme breaks down to biliverdin, bilirubin, and initially the bilirubin is unconjugated. Unconjugated bilirubin in the circulation is there along with the albumin forming a complex. So unconjugated bilirubin cannot pass in urine, okay? So cannot go in urine, right? So if there is unconjugated hyperbilirubinemia, urine bilirubin levels will never be elevated. On the other hand, what is going to be happening? Conjugated bilirubin is getting excreted in the intestine normally, and this will be converted to urobilinogen. It will be excreted in feces as stercobilin, in urine as urobilinogen. So all this will be coming in unconjugated hyperbilirubinemia. That means your unconjugated bilirubin level is going to be raised. Stool stercobilin is going to be raised. Urine urobilin or urobilinogen levels are going to be raised, but increased urine bilirubin will not be seen. In fact, even though these babies have jaundice, their urine is not high colored, okay, in RH incompatibility or hemolytic disease of newborn, right? So I hope you get the concept now. Moving ahead to a little bit about the treatment of neonatal jaundice. Jaundice in neonates a very, very important topic. In fact, other things that you must know are how to distinguish physiological jaundice of newborn from pathological jaundice. So we all know, pathological jaundice of newborn can appear in the first 24 hours of life, but physiological does not. Pathological jaundice is very severe, can involve the palms and soles, but in physiological jaundice, palms and soles are never stained yellow. So that is how from a given case scenario, you can make out whether the jaundice is physiological or pathological in a newborn, right? In a neonate on phototherapy, bilirubin is converted into, yes. What is the best answer? So Saurabh says B, Anjana B, okay, Akansha, Shalu, Aarti, Dr. Invisible, interesting name, Neelam Bhatia, Aarti, very good. So lumirubin is the best answer, right? So in a neonate on phototherapy, bilirubin is converted into lumirubin. So some quick important things about phototherapy. We all know in phototherapy, blue colored light is being used on the baby to, so that it brings down the neonatal jaundice that is happening, right? Now in phototherapy, the blue colored light is a very crude term. You need to know what wavelength of light is used. So the wavelength of light that is most effective for phototherapy. So some sources say it is 420 to 470 nanometers. Some sources say it is 450 to 490 nanometers. Okay. So you can choose a range anywhere between 450 to 460 nanometers. So if any of the options has 450 to 460 nanometers as the range, so that is the best or most effective wavelength for phototherapy, right? Very good. So what happens is, there are three mechanisms of actions of phototherapy. The most important mechanism by which phototherapy acts is, yes, anyone can tell me? So the most important mechanism is structural isomerization, wherein this bilirubin is converted into a structural isomer, that is lumirubin. And this lumirubin is easily, excreted from the kidneys, right? So that is what we were telling. Lumirubin was the answer here. Apart from that, there are some other mechanisms also by which phototherapy acts, like photoisomerization and photooxidation. Okay, right? Okay. Now, indications of phototherapy from a given case scenario. How do you make out whether the baby should receive phototherapy or not? So, the bilirubin level you have to look at. Suppose at 48 hours of life in an otherwise well baby who does not have any other risk, say there is no RH incompatibility, no other risk factors. But say at 48 hours of life, suppose the bilirubin of a baby is 20. It is falling here, right? So it is falling above this dotted line. So this baby should receive phototherapy. So that is how you decide. So you need to know some cutoffs beyond which the baby should receive phototherapy. So that will vary at different ages of life. Okay. Now, what are the adverse effects of phototherapy? Again, n number of times there have been questions. Bronze baby syndrome is an adverse effect of. The answer is phototherapy. So the adverse effects of phototherapy, just to enumerate some of the important ones because they have often been asked. So one is bronze baby syndrome, where the skin color of the baby changes. Apart from that, phototherapy can give rise to watery diarrhea, dehydration, okay, hypocalcemia, retinal toxicity, gonadal toxicity. So that is why you must have seen, when babies receive phototherapy, their eyes are covered and their genitalia is covered. Okay. So hypocalcemia, retinal toxicity, gonadal toxicity, and so on. And how can you increase the effectiveness of phototherapy? That is also once asked previously in your INI-CET pattern. So, effectiveness of phototherapy can be increased by increasing the exposed surface area of the baby, or by bringing the phototherapy light closer to the baby, right? Or by using the LED lamps. Now, moving ahead to the next question. Vitamin D deficiency causing neonatal seizures is? Yes, is it pantothenic acid? Is it pyridoxine? Is it thiamine? Is it riboflavin? Yes. Who's going to give me the correct answer? So Himani says A. No, I don't think that's right. Rohit B. Okay. Vishal, Himanshi, Nigar, Yogi, Kirti, Kishore. Yes, now everybody is getting it. So the vitamin deficiency causing neonatal seizures is, yes, of course, it is pyridoxine. So, pantothenic acid causes restless leg syndrome and burnings of hand and feet, things like that. Thiamine deficiency, we all know, causes beriberi. Riboflavin deficiency causes angular cheilitis, glossitis, and so on, oral ulcers, aphthous stomatitis. Okay. So, pyridoxine deficiency in infants basically can lead to, irritability, seizures. Okay. Irritability, seizures, failure to thrive can be there. Okay. Skin lesions can be there in the form of seborrheic dermatitis, glossitis, okay, seborrheic dermatitis, glossitis, and so on. Now, one very important point worth remembering, if you're getting a case scenario where a neonate is having difficult to control seizures, that means neonate is having seizure, you've given phenobarbital, seizures not responding, you've given phenytoin, seizures not responding. So, in difficult to control seizures or refractory seizures in newborn, pyridoxine deficiency is a very, very important cause. So, we must suspect and treat it. Okay. So, pyridoxine deficiency is a very important cause of refractory seizures in infancy. Okay, refractory seizures in infancy. So if you are getting refractory seizures in infancy, think of pyridoxine deficiency. Okay, and we can treat it. Some important quick facts about neonatal seizures, which are must know. What is the most common type of seizure in neonates? So it is, what is it? Subtle seizures. Okay, subtle seizures. The most important cause of seizure in neonates is, yes, what is it? So, very good. Himanshi, Mohammed Rafiq. Okay, febrile seizure, no, not in neonates. Febrile seizure, the typical age group is 6 months to 5 years, not a neonate. So, most common cause of neonatal seizures is hypoxia. The type of neonatal seizures with better prognosis is focal clonic seizures. The type of neonatal seizures with worse prognosis is myoclonic seizures. And what is the drug of choice for neonatal seizures? Again, a very, very must know area. What is the drug of choice for neonatal seizures? Come on. Waiting for your answers. The drug of choice for neonatal seizures. Let us see who can answer it. A chocolate from my side who answers. So, no, it's not valproate. Yes, Akansha, it's phenobarbital. Very good. So, Akansha gets a chocolate, right? And right, Nigar, Neha, Himani, very good. So, phenobarbital is the drug of choice for neonatal seizures. Okay, phenobarbital, right? And the investigation, the CNS imaging of choice that you can use in neonates is the transcranial ultrasound, right? Not a criteria for severe acute malnutrition. Again, n number of times you've got this question on, the diagnosis of severe acute malnutrition in children. So what is the answer here? Weight for height. So again, don't miss the word not here. Read your question very, very carefully. Don't just jump on to answering it without, just see the word severe acute malnutrition. Don't jump to answer it. Not a criteria for severe acute malnutrition is the question here. So weight for height less than -3, weight for age less than -3, mid upper arm circumference less than 115 millimeter, and bilateral pedal edema. So what do you think is the answer? So yes, we've got the answers from you already. Sandeep, Kishore, Madhumita, Ruchit, Aman, Sandeep, Satish. No, Satish, I'm afraid you're wrong. But most of you are answering it correctly. Ajay, Dhananjay, Aarti, Shalu. Yes. So not a criteria for severe acute malnutrition. The best answer is weight for age less than -3 standard deviations. So we must know what is the definition of severe acute malnutrition. So in a child between 6 months to 5 years of age, presence of any one or more of following. What are they? So weight for height. Remember, it is weight for height and not weight for age. Okay. Weight for height less than -3 standard deviations or Z score. That means severe wasting. Okay. It is also called severe wasting. What else? So mid upper arm circumference less than 11.5 centimeters or 115 millimeters, and symmetric bipedal edema of nutritional origin. Okay. Symmetric bipedal edema of nutritional origin. That means if a child is having edema due to nephrotic or any other cause, then we do not attribute it to malnutrition. So if a child is having edema, you've ruled out all the other causes and then you're attributing it to malnutrition, only then you include it as a diagnostic criteria. So that is how you diagnose severe acute malnutrition, right? What are the complications of severe acute malnutrition, or SAM? Yes, as you would want to say. So SAM ke complications you can remember by the mnemonic shielded. Okay, what's that? S for sugar deficiency or hypoglycemia. And how do you define hypoglycemia in a child with malnutrition? Blood glucose less than 54 milligram per dl. H for hypothermia. Hypothermia in malnutrition is defined as a rectal temperature of less than 35.5 degrees Celsius. I for infections, hypoglycemia, hypothermia, and infections form a triad in a child with malnutrition. EL for electrolyte imbalance, right? DE for dehydration, and another D is for deficiency of micronutrients. So that is how you can remember the complications of severe acute malnutrition, right? Moving ahead, a child transfers objects from one hand to another. What does it imply? Whether it implies visual motor coordination, explore small objects, object release, or comparison of objects. So again, in your, INI-CET pattern exam, this was exactly the question a couple of years back when, this was asked, what is the implication? We all know which milestone comes at what age, but what is the implication of that particular milestone? Again, also you should have some idea. Yes, so what are your answers? Let us see. So, Salman, Rashmi, Fahim, Dolly, Swati, Kishore, Nagesh, Manoj, Rohit, Fan, Sandeep Yadav, Priyanka, Himani, very good. So yes, it is comparison of objects. So we'll quickly see the implication of some of the important milestones, right? Among the gross motor milestones, holding the head steady means the child is now doing some visual exploration, okay? So visual exploration. Sitting without support again gives the child the chance to do some more visual exploration. So when the child is lying down, he's just looking at the ceiling or the sky. But once the child is able to sit, he will look around. So increasing visual exploration. Increasing visual exploration. Walks alone. If a child, once the child is able to walk alone, that means the child can control his proximity to parents. He can come near the parents or go away whenever he wants. Okay. So controls proximity to parents. Right? All right. Now moving ahead to some important fine motor milestones. Once the child is able to reach for objects, so what does that indicate? So that means the child is developing some visuomotor coordination. That means his brain is, so he's seeing something, his brain is receiving the signal, and he's able to translate it into some motor activity. So basically reaches out for object indicates visuomotor coordination. The child is now having some visuomotor coordination. Okay. Now, palmar grasp gone. So once the palmar grasp has gone, it now indicates that the child can voluntarily release objects. So the child learned to release objects. Okay, releases objects. Transferring objects from one hand to another. Suppose a child is transferring something from one hand to another. It indicates comparison of objects. The child can now compare objects. Okay, so comparison of objects. And pincer grasp means the thumb and the finger grasp indicates the exploration of small objects. Okay, exploration of small objects. And I'm sure all of you know what are the time frames on at which these milestones are going to appear, right? So I'm not going into that, but that again, of course, we should know. So then moving on to some social milestones, follows one step command with gesture. So that indicates the development of non-verbal communication. We are just telling like this and the child is coming to you. So that indicates non-verbal communication. Okay. So please add on these things to your notes if you haven't already done so. So these are important areas that you must know. Uncovers toys after seeing it hidden. So some toy, if you hide it and then the child will uncover it because of object permanence. He feels whatever is there should be there permanently. So that is the thing called object permanence. Okay. Now if a child pretends to drink from a cup, so that indicates symbolic thought. Symbolic thought. Okay. And if a child uses stick to reach a toy, that indicates, using, actions to solve problems. So links actions to solve problems. So the child is slowly learning to do these things, right? Moving to the language milestones. Now monosyllabic babbling, ah, ma, ga. So that indicates some experimentation with sound. Experimentation with sound. Okay. Says mama dada, so now the child begins to express himself. So expressive language appears. Expressive language. speaks 4 to 6 words. So now, he's beginning to acquire object and person names. So acquisition of object and person names. So acquires object and person names. And speaks two-word sentences is the beginning of grammatization. So who will tell me two-word sentences come at what year of age? Come on, two-word sentences come at what year of age? Yes, waiting for your reply. Two-word sentences at what age? So nigger, you're right, it is 2 years. Salman, Kishore, Prithvi, right. So remember, number of words a child can put in sentence is equal to his age in years. So 2 years, two-word sentences, 3 year, three-word sentences, 4 year, four-word sentences, and so on. Okay. Now, which of the following is a X-linked dominant condition? Is it SMA, spinal muscular atrophy? Is it Duchenne muscular dystrophy, DMD? Is it Rett syndrome, or is it achondroplasia? Right? So multiple times again you get questions, these direct questions on inheritance of various common diseases. Yes. So which of the following is a X-linked dominant condition? Come on, guys. I don't want a wrong answer on this one. This is supposed to be a revision class. Yes. So Rohitansh, no. Satrupa, a good doctor. Yes. Ranjini, Subhashish, you're right. Subhashish, yes. Shalu Gupta, you're right. Kratika, yes. So it is Rett syndrome. Spinal muscular atrophy, it has an autosomal recessive inheritance. Duchenne muscular dystrophy, we all know, has an X-linked recessive inheritance. Achondroplasia is a classical example of autosomal dominant inheritance. And Rett syndrome is a classical example, friends, of X-linked dominant inheritance, right? So Rett syndrome, we know the most common mode of inheritance is X-linked dominant. Multiple genes can be involved in Rett syndrome, but the most common gene involved is the MECP2 gene, okay? And because it is an X-linked dominant condition, it is seen more commonly in girls. The head size at birth is normal, okay? But the child then goes on to acquire microcephaly. So at birth, the head size is normal, but at say 6 months, 9 months, 1 year of age, you will see that the head size has not increased as much as it should have. So acquired microcephaly is what is seen. And the typical feature, which is diagnostic, is stereotypic hand wringing movements like this, okay? So stereotypic hand wringing movements, okay? Hand wringing movements, right? Okay. Now, a quick recap of some important examples of various kinds of inheritance. So, autosomal dominant inheritance, you can remember by the mnemonic heavy dominant, okay? Heavy dominant. I'm sure all of you remember it. Just a quick recap. So H for hereditary spherocytosis, E for Ehlers-Danlos, A for achondroplasia, V for von Willebrand, Y is the Y in pseudohypoparathyroidism. Now dominant, D for dystrophia myotonica, O for osteogenesis imperfecta, M for Marfan, I for intermittent porphyria, N for Noonan syndrome, A for adenomatous polyposis coli, another N for neurofibromatosis, and T for tuberous sclerosis. Okay. Moving on to some important autosomal recessive disorders, you can remember it by the mnemonic A, B, C, D, E, F, G, H, right? So A for albinism, B for beta thalassemia, C for cystic fibrosis, D for deafness, sensory neural hearing loss. Most commonly, it is due to the GJB7 gene mutation. E for emphysema, F for Friedreich's ataxia, G for Gaucher disease, and H for homocystinuria. Remember, friends, most of the metabolic disorders, inborn errors of metabolism, have autosomal recessive inheritance, barring a few. Okay. So we'll be coming to the exceptions. Moving on to X-linked recessive disorders, the mnemonic here is girls do care for chawal. Okay, so girls do care for chawal. Chawal, rice. Right? So G for G6PD deficiency, D for Duchenne muscular dystrophy, C for color blindness, F for Fabry disease. So Fabry disease is one of those inborn errors of metabolism which has X-linked recessive inheritance. C for chronic granulomatous disease, H for hemophilia A and B, and Hunter disease is another inborn error of metabolism which has got X-linked recessive inheritance and not autosomal. Okay. Again, A for agammaglobulinemia, we all know Bruton's X-linked agammaglobulinemia. W for Wiskott-Aldrich syndrome, very important disorder, often asked in your MCQs. A for albinism and L for Leishman syndrome, right? Moving ahead to a few examples of X-linked dominant inheritance, they are CAR. Okay, so C for Charcot-Marie-Tooth disease, A for Alport, R for Rett, and another R for rickets, that is hypophosphatemic type of rickets, and the gene involved here is the PHEX gene. phosphate regulating gene with homology to endopeptidases on the X chromosome, right? Moving ahead. Now, an affected male does not have affected children, but an affected female always has affected children. What is the type of inheritance? Right? Simple. So is it X-linked recessive? Is it autosomal recessive? Is it X-linked dominant? Is it mitochondrial? So very good. Rajendra, Alia, Jayashree, Dr. Sarika, Himani, Avinash, Nikhil, Rohit, very good. So it is mitochondrial inheritance indeed, yes. And what will the pedigree look like in mitochondrial inheritance? You can see that this female is affected and all her children are affected. Okay. Similarly, this female is affected, all her children are affected. But this male is affected, so his children, this male is affected, but his children are not affected. Right? So this is a typical example of a pedigree showing mitochondrial inheritance. Now, why is it so? Because, from the mother's ovum has the cytoplasm, and right, so all the cytoplasm and all the mitochondria are there in cytoplasm, we know. So all the cytoplasmic organelles or mitochondria come from the mother, while from the father only the sperm's head is penetrating it. Okay, so the mitochondria which the baby receives is mostly from the mother. So that is why, if the mother is affected, all the babies are having the disease, right? Now, moving ahead, which amino acid does not need to be restricted in diet in MSUD, maple syrup urine disease? To answer this question, you need to know what is the problem in MSUD. So what is the problem? We know there is the problem in the metabolism of branch chain amino acids. Now, which are the branch chain amino acids? They are leucine, isoleucine, and valine. So which amino acid does not need to be restricted in diet in maple syrup urine disease? Very good. Almost all of you are right. Prithvi, Nigar, Abdullah, Priyanshi, Neha, Aditi, Swati, Vikrant, Satrupa, very good. So methionine is the correct answer because there is a problem in the metabolism. Leucine, isoleucine, valine, they are accumulating in the body. So we have to restrict them in diet. But methionine we need not restrict in maple syrup urine disease. Okay. Moving ahead, a 5-year-old boy has coarse facial features. You know what is coarse facial features? Puffiness around the eyes, depressed bridge of nose, then thin lips, and So coarse facial features, enlarged head, corneal opacity, hepatosphenomegaly, protuberant abdomen, breathing difficulty with obstructive sleep apnea, and cardiac wall thickening. What is the likely diagnosis? So, coarse facial features, hepatosphenomegaly, corneal opacity, and then all these features mentioned are compatible with a diagnosis of mucopolysaccharidosis. Now, which type of mucopolysaccharidosis? Because corneal opacity is there. So it will be very good. Sandeep, Jayashree, Swati, Harsh, yes. Madhumita, yes. So it is Hurler disease. Okay. So coarse facial features with these clinical features and corneal opacity, hepatosphenomegaly, your answer is Hurler disease. Hunter disease usually has similar features, but corneal opacity is not there. Fragile X syndrome will not present like this. Fragile X syndrome individuals are going to have large ears, large jaw, macroorchidism, elongated kind of a face, and intellectual disability. Tay Sachs disease is another storage disorder where hepatosphenomegaly is not commonly seen. Okay. So Hurler disease is the best answer. Moving ahead, a 2-year-old boy was admitted with recurrent bloody stools. So you have a 2-year-old boy with recurrent bloody stools, atopic dermatitis like rash, and petechiae. Okay. On CBC, his hemoglobin was 10.8. On CBC, his hemoglobin was 10.8 gram per DL, PLC was 10,400, and platelet count was 20,000. What is the next best step to establish the diagnosis here, right? So is it antiplatelet antibody assessment, screening for WASP expression, bone marrow aspiration, LFT, RFT? What do you think is the right answer? So I'm getting mixed bundle of answers here, but Swati, right? Avinash, Akansha, okay. So 50-60% of you are getting it right. So this is a typical case scenario of Viscott-Aldrich syndrome. In Viscott-Aldrich syndrome, we know there is an abnormality in the, a gene on the X chromosome, right? So in Viscott-Aldrich syndrome, there is a gene abnormal in the X chromosome short arm. As a result of this, which there is a defective production of the VASP protein, okay, Viscott-Aldrich syndrome protein. So because of that, there in Viscott-Aldrich syndrome, you get a triad of microthrombocytopenia. Okay, small size platelets are there and thrombocytopenia is there. Okay, atopic dermatitis like rash is there, right? Atopic dermatitis like rash. And you have recurrent infections because of immunodeficiency. okay, recurrent infections, right? So here, to diagnose this condition, antiplatelet antibody assessment is not going to help. Screening for VASP expression, yes. Bone marrow aspiration, no. LFT, RFT, no. So screening for VASP expression is the best answer. So, from a given case scenario, don't get bogged down. Just try to see that, try to pick up the cues. There is recurrent bloody stools. Atopic dermatitis like rash is there. There is thrombocytopenia. So you can fit it in. The triad of Viscott-Aldrich syndrome. And we know Viscott-Aldrich syndrome, VASP protein is involved. So of course you will screen for that expression. So, it is all about trying to synthesize the information given from the question, trying to integrate things together and trying to utilize it. Okay. So it is, high time. It is just before your exams. So I would, when I gave the AIMS entrance exam, in my last few days of preparation, I made sure all the topics from the previous year MCQs were thoroughly covered. And somehow that helped me a lot in getting the rank 7 at AIMS that I got in my first attempt, right? So each of you has the potential to get that. So what is very, very important is, you must focus on the important areas. You must have in-depth knowledge about the important areas. Don't expect a verbatim repeat question in your exams, but expect that the topics are usually the same. Okay, the important topics remain important, whether it is INI-CET exam, whether it is, NEET PG, whether it is your FMG entrance exam, okay, FMG exam, exit exam. So remember to do those topics very, very well. And I'm sure all of you have the potential of getting that rank and of getting, whatever you wish to. So moving ahead, this 4-year-old girl presented with low-grade fever, sore throat, and fluid-filled lesions on the, so you can see these fluid-filled lesions are there on the palms and sole, and ulcer-like lesions on upper lip. Okay. Some of her friends in the same class also reported similar features. So you can see the oral ulcers here, right? So what is the probable diagnosis? You can see the oral ulcers here. Redness is there, okay, and some vesicles and blisters are also there. So what is the probable diagnosis here? Is it herpetic gingival stomatitis? Is it chickenpox, measles, or hand, foot, and mouth disease? Very good. Almost all of you have answered it correctly. Yashti, Himani, Jack, Altaf, Sumit, Snowflakes, that's a lovely name. Faiz, Avinash, Rizwan, very good. So this is hand, foot, and mouth disease. Okay, so hand, foot, and mouth disease, recently we've been seeing an epidemic. So all the more reason you can expect a question from this. A case scenario based question can also come. So hand, foot, mouth disease, the most common causative organism for that is the Coxsackie virus. Coxsackie A16. Apart from that, other varieties of enterovirus and Coxsackie virus and all ecovirus also can also cause it. So it is a mild and self-limiting illness where you get, you can get oral congestion of the oral mucosa, okay, and there can be pharyngitis, there can be oral ulcers, painful ulcers can be there, vesicles and blisters can be there on the palms and soles. It is usually a self-limiting illness. Usually no complications are seen, and most of you are getting a history of, many school children and friends being involved. So this is the hand, foot, mouth disease, right? Moving ahead, a 1-year-old boy is brought to you for vaccination. He has received only one shot of DPT. So 1-year-old boy, excuse me, he has received only one shot of DPT at 6 weeks. What should you do now? So A, no need for giving DPT now. B, give second dose of DPT shot. C, restart DPT regime from the first dose again. D, start DT regime. So what is the best answer? Very good. Again, Paresh, Anurag, Princey, Dolly, Sarika, very good. Okay. Vikran, no, I'm afraid C is not the answer. Right. So, give the second dose of DPT shot as the best answer. So, catch-up immunization, again, you must be aware of. So, what happens, if a child is partially immunized, whenever the child comes to you, you have to start from where the child had stopped. So, this child has already received one shot of DPT. So, when the child comes next time, you're going to give second dose of DPT. Okay, you're not going to, stop DPT, or you're not going to repeat the first dose. Okay, or you're not going to start the DT regime. That's not required. So this is a 1-year-old boy, so you give the second dose of DPT. So for an unimmunized child who comes to you, or a partially immunized child who comes to you, you have to see the age appropriate immunization which is pending, and you have to also take into account the doses which the child has already received. Okay, like if the child had received 2 doses of DPT already, we would give the third dose of DPT and not start from the first. Okay, so that is how you do it. Okay, now A child with steroid-dependent nephrotic syndrome has been on daily oral steroid for 3 weeks. All of the following are true about the vaccination of this child except. So this is a bit of a tricky question, right? So a child on steroids or immunosuppressive agents or an immunocompromised child. So what should you remember regarding his vaccination, his or her vaccination? So all of the following are true except. So give all immunization according to the schedule, or the sibling should not be given OPV, or give killed vaccines. Pneumococcal vaccine should ideally be given before commencing the treatment. What do you think is the right answer? Okay. So all of the following are true except. So here again I'm getting a mixed bag of answers. So Vishal says B, Avinash says A, many of you are saying A, many of you are saying B, so you look confused, and someone has also said C, Nagesh. Right, so let us try to understand this. So this child is immunocompromised, okay? And we are asking all of the following are true about the vaccination of this child except. Give all immunization according to schedule. Is it true? In an immunocompromised child, will you give live vaccines? No, this is not true. So this is false, right? Siblings should not be given OPV. Is it true? OPV is a live transmissible vaccine. So if another child in that household is given OPV, he is going to excrete the polio vaccine virus, the live virus in his stool. And that virus can infect this child. So, the household siblings of that child should also not be given live transmissible vaccines. So siblings should not be given OPV is true. Give killed vaccines. In immunocompromised child, we can give vaccines, killed vaccines, that is true, right? Pneumococcal vaccine should ideally be given before commencing the treatment. That is also true, right? So the best answer to this question is A. Give all immunization according to schedule. We don't do that. We avoid live vaccines. Okay. Moving ahead. Interception is caused by which of the following vaccines? Now this is an easy one. I'm sure all of you know the answer. Come on, quick. So we are doing a fastest finger first. Right. So Bharat, Yashti, Himanshi, Sarika, Satrupa. So most of you are right. So it is rotavirus vaccine. So we need to know the important side effects of some of the vaccines. So BCG, what are the important side effects? So BCG can lead to osteitis. It can cause BCG lymphadenitis. So that is how, from a given question, you know that what all things we should read around it. We should know around that topic. So BCG lymphadenitis, then there's something called disseminated BCG infection. Okay. Disseminated BCG infection. Now, DPT the side effects of DPT are like persistent inconsolable cry. Okay. Persistent inconsolable cry. Then there's something called hypotensive hyporesponsive episodes. Okay. HHE. Hypotensive hyporesponsive episodes. There can be anaphylaxis. There can be seizures. Okay. Hyporesponsive episodes. There can be anaphylaxis, there can be seizures. MMR vaccine is known to be associated with a measles-like illness. Okay, there can be measles-like illness. There can be thrombocytopenia. Okay, thrombocytopenia. Previously, there were reports of linking this vaccine to autism, but now the studies have not found any evidence. OPV we know can cause VAP, vaccine-associated paralytic poliomyelitis, and rotavirus. We already mentioned a very important side effect as well as a contraindication is interception. Right. So moving ahead, the pentavalent vaccine which is used in India's national immunization schedule contains which of the following? Is it diphtheria, pertussis, tetanus, Hep B and Hib? Is it diphtheria, pertussis, tetanus, pneumococcal Hep B? Or IPV, PCV and DPT? Or is it DPT plus polio plus Hep B? So the pentavalent vaccine in our national immunization schedule consists of which all? Yes. So Sachin, Avinash, Himanshi is not right here this time. But yes, most of you are right. Dhananjay, Misaki, Snowflakes, Medico. Okay. So the pentavalent vaccine, which is used in India's national immunization schedule currently, has this D, P, T, Hep B, and Hib. Okay, all these are combined. But what else you have to give separately? The pneumococcal vaccine is given separately. The injectable polio vaccine is given as FIPV, fractional doses of IPV, that is also given separately. Right? Okay. Now, moving ahead, a 10-year-old male child, okay, don't get bogged down by the length of the question, okay. So 10-year-old male child presents to the hospital with complaints of cyanosis, fatigue, and dyspnea. Okay. On further examination, the patient presents with equal cyanosis in both upper limb, fingers, and toes. Okay. And the patient presents with features history of pulmonary artery hypertension, like loud P2. Okay. The patient's past history reveals the presence of frequent chest infections in childhood. You have made a provisional diagnosis of Eisenmenger syndrome. In which of the following conditions reversal of shunt is not possible? So, in essence, after going through the case scenario, you can make out probably this child has something called some heart disease like VSD, because of which child was having recurrent chest infections, and now Eisenmenger syndrome has developed, and the child has now developed cyanosis. Okay, but now the question is asking in which of the following conditions reversal of shunt is not possible. So it is a clear-cut question now. So very good. Afreen, you're right. Rohitansh, right. Crypto, no. Neelam, yes. Okay. Yashti, right. Jaya, okay. So this is a child with, so which the answer to this question is in which of the following conditions reversal of shunt is not possible is stop. This ASD, VSD, and PDA. These three are lesions where you have a left to right shunt. That means blood goes from the systemic circulation to the pulmonary circulation. Okay. So excess of blood goes to pulmonary circulation. The child has recurrent episodes of pneumonia, heart failure, and so on. Once Eisenmenger syndrome develops, what will happen? Reversal of shunt will happen in these. So once there is development of Eisenmenger syndrome or irreversible pulmonary vascular changes develop, then instead of left to right shunt in these diseases, there is going to be right to left shunt. So reversal of shunt happens in these three diseases, right? But in tetralogy of Fallot, there is already a right to left shunt. That means less blood is going to the pulmonary circulation, more blood is going to the systemic circulation, and reversal of shunt is never going to happen in top. Okay, so tetralogy of Fallot is the best answer to this question, right? Moving ahead, in which congenital heart disease all the four chambers have equal oxygen saturation of blood? So is it ventricular septal defect, atrial septal defect, total anomalous pulmonary venous connection, transposition of great arteries? Now again, this is a some bit of a concept based question. Let us see who can answer it. Okay, so Himanshi, Akansha, Asha, Kishore, Avinash. Very good. So most of you are correct. It is total anomalous pulmonary venous connection. Equal oxygen. Hello friends. Please confirm if you're able to see my screen and if you're able to hear me. It was some internet issue. Yes, I'm waiting for your response so that we can resume. Yes, so we are good to go. Right? So TAPVC we were talking about. So in TAPVC, what is happening? Let us see. Total anomalous pulmonary venous connection. So in TAPVC, what happens is, the SVC, the blood from superior vena cava, the blood from inferior vena cava, as well as the blood from the pulmonary vein, all of them are draining into the right atrium. Okay, so you can see that there is a complete mixing of blood in the right atrium, right? And that blood is going via ASD to left atrium also, that blood is going to the right ventricle also, and via VSD to the left ventricle also. So all four chambers of heart have got equal oxygen saturation in TAPVC, that is total anomalous pulmonary venous connection, right? AB7 is telling you he is not able to hear. Please confirm if you are able to hear my voice or not. Please confirm if you are able to hear my voice. I need a yes before I can proceed. Yes, Nikhil says fine. Thank you. Thanks, Kajal, Avinash. Okay, let's move ahead. So, and what happens in TGA now? Let us see. TGA, friends, is what? TGA is transposition of great arteries. What happens in TGA? So, in TGA, there is a parallel circulation. So, what happens is, the right blood goes from the right atrium to right ventricle, but from the right ventricle, instead of, the pulmonary artery, comes the aorta in TGA. From aorta, the blood goes to the body, while via SVC and IVC, it again comes to the right atrium. So deoxygenated blood is there in the right atrium and right ventricle, and that is circulating throughout. And what is happening on the left side? On the left side, left atrium, blood is going to left ventricle. From left ventricle, instead of aorta, comes the pulmonary artery in TGA, transposition of great arteries, right? It goes to the lungs, gets oxygenated, comes back via pulmonary veins to the left atrium. So going to the lungs and coming back from the lungs to the left atrium, left ventricle. So left side is having oxygenated blood. So you can see clearly that all the chambers of heart are not having equal oxygen saturation here also. So the best answer was TAPVC, and we get the concept why is it so, right? Moving ahead, a 3-year-old girl presented with fever and splenomegaly. In which condition splenomegaly is not present? So a child is having fever and splenomegaly, and sometimes you may also get a investigation findings, pancytopenia and all may also be present. So we know that splenomegaly in leukemias, lymphomas, you get splenomegaly. In hairy cell leukemia also you get splenomegaly. But aplastic anemia, splenomegaly is not there. So in which condition splenomegaly is not present? The answer is aplastic anemia. Good. Paresh, Ashu, Himanshi, Amisha, very good. Dr. Invisible. Okay. So that you're right. So you can get case scenarios like this where you have to come to the diagnosis based on the important clinical features which are provided, right? Moving ahead, a 14-month-old baby, 14-month baby who has presented with severe pallor, had a previous blood transfusion history at 9 months and 13 months. He also had frontal bossing and prominence of cheeks. On abdominal examination, there was hepatosplenomegaly. On investigation, his hemoglobin was 6.3, that means he has anemia. TLC was fine, 12,200. Platelet count is also okay, 3 lakh. What should be the investigation for definitive diagnosis? So whether parental HPLC or globin gene sequencing or serum ferritin or bone marrow aspiration. Yes, what do you think is the answer? Okay, so Karishma, Dr. Invisible, Kanav, Himanshi, Anjana, Dhananjay, Madhumita, Charita, all of you are right. Okay. So this appears to be a case of, a chronic hemolytic anemia like thalassemia. You have a 14-month-old baby and severe pallor is there. 2 times he has received blood transfusion. Hemolytic kind of facies is there and anemia is there, but the other 2 cell lines are preserved. So we are looking probably we are looking at a case of chronic hemolytic anemia, which is most commonly thalassemia. So parental HPLC is not going to give you, it will give you some clue, but it will not give you the definitive diagnosis. Mind the question. What should be the investigation for definitive diagnosis? So if you ask definitive diagnosis, then you have to demonstrate the mutation in the globin gene, which might be responsible. Okay, there can be hemoglobinopathies. Okay, there can be various abnormalities. Which can give rise to it. So the definitive diagnosis would be by globin gene sequencing. Serum ferritin is not going to help. It will only tell whether iron overload is there or not. Bone marrow aspiration is not going to help in this situation. It is more helpful in situations like pancytopenia. Parental HPLC might give some clue, but will not give you the definitive diagnosis. Okay. So mind the questions in the words used in your question very, very carefully. Now, not a feature of severe dehydration. A seemingly very simple question, but has been asked n number of times and very, very important for you to have this concept about dehydration and diarrhea in children. Very important topic. Okay. So severe dehydration, not a feature of severe dehydration. Child thirsty, drowsy child, skin retracts very slowly, sunken fontanelle. Okay, Mohammed Rafiq, you're right. Neha, Devyani, Himanshi, Swati, right. So some of you are answering incorrectly, but most of you are right. So not a feature of severe dehydration. So let us see how to assess dehydration in a child with diarrhea. So assessment of dehydration in a child with diarrhea is very, very important, a must-know area. Okay, how do you do that? So sensorium. In a child with no dehydration, the sensorium is going to be normal. The child will be well and alert. And in some dehydration, the child will be restless and irritable. Okay, restless, irritable. In severe dehydration, the child is going to be lethargic. The child can be floppy. Okay. Eyes, if you look at, it will be normal in no dehydration, sunken in some dehydration, very sunken in severe dehydration. Tears present in no dehydration, absent in some and severe dehydration. Mucosa will be normal and wet in no dehydration, dry in some dehydration, very dry in severe dehydration. Thirst is going to be normal. The child is not thirsty. Okay, normal thirst. Okay, in no dehydration. Some dehydration, the child is very thirsty and eager to drink. Thirsty and eager to drink. While in severe dehydration, the child is not able to drink. So if a child is thirsty, that indicates some dehydration and not severe dehydration. Okay. So severe dehydration, the child is not able to drink. Okay. Not thirsty. Skin pinch goes back quickly, in no dehydration. It goes back slowly, but in less than 2 seconds. Slowly, but in less than 2 seconds in some dehydration. Very slowly, taking more than 2 seconds in severe dehydration. So coming back to our question, so you can see that severe dehydration, the child is thirsty in some dehydration. Okay, in severe dehydration, the child cannot be thirsty. Okay, right? Drowsy child you can get in severe dehydration. Skin retracts very slowly is also right. Sunken fontanelles is also very right. So child thirsty is the best answer. It is not a feature of severe dehydration. Okay. Moving ahead, what is the treatment of dehydration in a child with diarrhea? I'm sure all of you know it. Okay, so remember, even if a child with diarrhea has no dehydration, still you are going to give WHO ORS. And please revise the composition of WHO ORS, very, very important. Okay, the osmolality 245, that is also again very important. If there is some dehydration, how do you treat? Some dehydration, we give 75 ml per kg over 4 hours. So this fluid is ideally given orally as ORS if the child is able to take orally. If the child is not able to take orally, then you can give as IV fluids. And in severe dehydration, you have to give around 100 ml per kg fluid. Okay. 100 ml per kg. And this 100 ml per kg in a child less than 1 year of age, you give it over 6 hours. In a child more than 1 year of age, you give it over 3 hours. Right? Okay. So, and apart from that, of course, zinc is used in the treatment of diarrhea in children more than 2 months of age, and you have to continue normal diet. Remember, in acute diarrhea, you need not do any dietary modification. Moving ahead, what is the most common cause for urine flow obstruction in a male baby? So is it urethral atresia? Is it ureterocele? Is it posterior urethral valve? Is it anterior urethral valve? Waiting for your reply. Yes, most common cause for urine flow obstruction in a male baby. Very good. So Malay, Himani, Asha, Himanshi, Sarika, Adil. So all of you are getting it right. It is posterior urethral valve. So in posterior urethral valve, if a male baby is there with features of urinary obstruction, the child is having straining while urination, or mother gives a history the child has improper urinary stream. All of these conditions you suspect posterior urethral valve. Okay. Moving ahead, you have a 4-year-old male child with body weight of 15 kgs, height of 100 centimeters, admitted with renal failure. His blood urea was 100, serum creatinine was 1. What is the closest calculated eGFR, estimated glomerular filtration rate in this patient? Yes, who can answer this? Estimated GFR? Very good. Yes, Himanshi, we have to use Schwartz formula. What is Schwartz formula? Yes, tell me what's the Schwartz formula? So Schwartz formula is used to calculate estimated GFR in children. According to Schwartz formula, the estimated GFR is equal to K into the height of the child by the serum creatinine, where K is a constant and the value of K is usually taken as around 0.4 or 0.43 to be more precise. Height is taken in centimeters and serum creatinine is taken in milligram per dl. So you can see as serum creatinine is in the denominator. So more the serum creatinine, lesser will be the estimated GFR of the child. Now, put that and see what you're getting. So, let us see what is the estimated GFR according to Schwartz formula, and by the time, let's see if someone has answered it correctly. So, Jayashri, you are right. Himanshi, Kevin Dorai, okay. So, Avinash is also right. Yes. So, let us see. Estimated GFR here will be 0.4 or 0.43 to be more precise. Okay. 0.4 into what is the height of the child? The height is 100 centimeters. So, into 100 divided by creatinine is 1 milligram per dl 1. So, that is 40. Okay. So 40 is the best answer. And one more thing to note here, friends, is the unit of GFR. The unit of glomerular filtration rate is milliliter per minute per 1.73 meter square. That means you have to take into account body surface area as well. Okay. So B is the best answer. You need to know how to calculate the estimated GFR. Okay. Using this Schwartz formula. Right. Moving ahead, a 5-year-old child is brought to you with cola colored urine. Okay, cola colored urine and oliguria, that means decreased urine output since 3 days with mild facial puffiness. Fetal edema with 3 plus proteinuria. BP 126/90 is high for a 5-year-old child. Urine examination shows RBCs 100 for hyperfine and granular cast. Which of the following usually does not present with these findings? So mark the question, which of the following doesn't present with these findings? So typically, friends, this is a case scenario of nephritic syndrome, right? Why so? Because see, you are getting hematuria, and a cola colored urine is there, decreased urine output is there, mild edema is there, okay? Hypertension is there, and proteinuria is there. So all these are compatible with a diagnosis of nephritic syndrome, right? Or glomerulonephritis, underlying pathology wise, if we say, right? So what will be the best answer? Will it be minimal change disease, membranous glomerulonephritis, FSGS, focal segmental glomerulosclerosis, or IgA nephropathy? So which of these usually does not present with these findings is the question. So most of you are right. Kanav, Rizwan, Anjana, Bhupendra, Dreen, okay, Mridul, yes. So it is minimal change disease. Minimal change disease usually will not present with hypertension, will usually not present with a nephritic kind of picture. It usually presents with nephrotic syndrome, and which is usually steroid sensitive also. Okay. But membranous glomerulonephritis, focal segmental glomerulonephrosis, IgA nephropathy, all these can present as, and typically they present usually as nephritic syndrome. Okay. So the best answer here is minimal change disease. And of course, nephrotic syndrome, nephritic syndrome, very, very important must know areas. Okay. And acute kidney injury, as we already discussed, how to calculate GFR and all. Okay. Moving ahead to yet another important topic, a child presents with high grade fever. Okay. So a child presents with high grade fever, stridor, and develops swallowing difficulty and drooling of saliva. Child is not able to swallow his own saliva. On direct laryngoscopy, the epiglottis appears red and swollen. Along with the airway management, which of the following needs to be given? So first, in these case scenario based questions, try to come to a diagnosis. Only then, of course, you can think about the management. So what do you think is the diagnosis here? Yes, A is right, and Himanshi, you're right. It is acute epiglottitis. Very good. So the diagnosis here is acute epiglottitis, right? Okay, because the child has high grade fever, stridor is there, swallowing difficulty is there, and epiglottis is appearing red and swollen. So this is a sick child with stridor, upper airway features, so acute epiglottitis. Acute epiglottitis we know is a bacterial illness. So the most common organism responsible is Streptococcus. Previously it was thought to be H. influenzae, but now in the immunized children, Streptococcus is the most common cause. Because bacterial cause is most common, IV antibiotics need to be given in this condition. Okay. So steroids, racemic epinephrine nebulized, diphtheria antitoxin, not useful here. A close differential diagnosis would be croup, where you are going to use steroids and nebulized racemic epinephrine. Okay. So you can see here, can you appreciate friends? This is the normal epiglottis, right? This is the normal epiglottis, and this is the epiglottis which is swollen and red, inflamed. So this is the cherry red epiglottis which is seen in acute epiglottitis. Okay. It is called cherry red epiglottis. Okay. And you can see the thumb sign here. Can you see this thumb sign? The inflamed epiglottis in the lateral view of neck. Okay. So all these are features of acute epiglottitis, and they can come as image-based questions for you. Okay. This is not omega sign. This is acute epiglottitis. So acute epiglottitis, the treatment will be supportive care plus IV antibiotics. While in croup, sometimes a lot of times you also get questions on croup. So along with this acute epiglottitis, you also need to be aware of croup. So in croup, the child will be having, low grade fever, okay, and prodromal features will be there will be some cough, stridor will be there, some breathing difficulty can be there. Croup is a viral illness, and it is less severe than your acute epiglottitis. Okay. So in the treatment of croup, apart from so in the treatment of croup, so treatment of croup is also often asked. So in the treatment of croup, you give oxygen, you give supportive care, that means you give IV fluids, monitor the child. In addition, we use steroids in the form of dexamethasone, which can be given a single dose, oral or IV. Dexamethasone, oral, IV, or even IM. Okay, intramuscularly is commonly used. So single dose dexamethasone, oxygen, IV fluids, and nebulized epinephrine. So these are the things which are used in the treatment of croup, okay, or acute laryngotracheobronchitis. Remember, there is no role of using antibiotics in croup because croup is a viral illness. So very important to read around the topics, right? Moving ahead, a 6-year-old child. So another 10 more minutes I'll take. So a 6-year-old child came to the emergency department with history of multiple episodes of myoclonic seizures. On further examination, the patient presents with developmental delay, and EEG shows slow waves in the awake state and polyspike bursts while sleeping. The patient's mother gives a past history of difficult to control tonic-clonic seizures. So previously the child was having tonic-clonic seizures, now the child is having myoclonic seizures. There is developmental delay also. The seizures are difficult to control also. Which of the following is the most probable diagnosis? Yes. So Adil, you're right. Adil, Rohitansh. Okay. Ashu is not right. Jayashree is right. Okay. So thanks, Himanshi, for the east or west. That's a nice one. So that's the best line which makes my day today. So The best answer to this question, this is not West syndrome. This is not Otahara syndrome. Okay. Early infantile epileptic encephalopathy doesn't look like. So this is basically a case of Lennox-Gastaut syndrome. Lennox-Gastaut syndrome, the typical features are multiple seizure types. So like this child has myoclonic seizures also, this child has tonic-clonic seizures also. And the seizures are difficult to control. This child has difficult to control seizures. And the EEG is showing slow wave and spikes. And the child also has developmental delay. So all these are compatible with the diagnosis of Lennox-Gastaut syndrome. Okay. Moving ahead, ACTH, adrenocorticotropic hormone, is used in the treatment of which of the following? Is it juvenile myoclonic epilepsy? Is it Rolandic epilepsy? You know what is Rolandic epilepsy? Benign epilepsy with centrotemporal spikes. West syndrome or Lennox-Gastaut syndrome? Yes, this is a simple one relatively. So Brahma, Himanshi, Bhupendra, yes. Nigar, Aarti, very good. Shiana, so all of you are right. So ACTH is used in the treatment of West syndrome. Now, what is West syndrome? So West syndrome is basically a triad. Okay, three things are seen. What are they? So West syndrome has infantile spasms or salam attacks. So infantile spasms or flexor spasms or salam attacks like this. The child will suddenly have these salam attacks. Okay, infantile spasms or salam attacks, developmental delay is there. And on EEG, you get a typical chaotic kind of pattern, which is called hips arrhythmia. Hips arrhythmia. Okay. So if you get a triad of these three things, then that makes the diagnosis of West syndrome. Infantile spasms or salam attacks, developmental delay, and hips arrhythmia. The treatment of choice for West syndrome is, as we mentioned, injection adrenocorticotropic hormone. But remember, in a child with tuberous sclerosis, if there are infantile spasms, so infantile spasms in a child with tuberous sclerosis, the drug of choice then becomes vigabatrin. Okay. So as such, the treatment of choice for West syndrome is injection adrenocorticotropic hormone, but in a child with tuberous sclerosis with infantile spasms, the drug of choice is vigabatrin. Okay, right. Moving ahead, a 3-week-old neonate. So we have a 3-week neonate with ambiguous genitalia. That means you're not able to make out whether it is a male child or a female child based on the genitalia. Presented with shock. That means hypotension, poor perfusion. On investigation, the sodium was 127, the potassium was 6.5. Which of the following is the drug of choice in this situation? So the baby is having ambiguous genitalia, is having shock, is having hyperkalemia. So all these point towards an underlying diagnosis of CAH or congenital adrenal hyperplasia, which is most commonly due to 21-hydroxylase deficiency, right? In order to diagnose that, we use 17-hydroxyprogesterone levels. The 17 OHP levels we usually do, which will be elevated in 21-hydroxylase deficiency. Now, what is to be used in the treatment? Let us see what you have answered. Shiana, okay. Satrupa, okay. So Paresh is right. Sani, Anjana, Meet, Beneath, Paresh. Okay. So hypertonic saline is not to be used. Okay. And especially the sodium is 127 only. If it would have been say less than 120, one might use hypertonic saline low dose to build it up quickly. But the drug of choice here for the treatment of CAS due to 21-hydroxylase deficiency is hydrocortisone. You have to use hydrocortisone. Okay. Broad spectrum antibiotics. You might use it if you think of septic shock. Okay. Spironolactone not very useful as such. So, the best answer to this question is hydrocortisone. Because you're thinking it to be a case of congenital adrenal hyperplasia due to 21-hydroxylase deficiency, you have to replace glucocorticoids and mineralocorticoids. So, glucocorticoids in the form of hydrocortisone, mineralocorticoids in the form of fludrocortisone. So, that is the drug of choice or treatment of choice in this condition. Okay. So CAH, again read up the various types, the various enzyme deficiencies, even prenatal diagnosis is possible, and confirmatory diagnosis of course is by genetic mutation demonstration. Okay. Now, which of the following diseases has impaired collagen synthesis? Yes, again a straightforward question. Is it rickets, scurvy, beriberi, night blindness? So Himanshi, Brahma, Asha, Madhumita, Janvi, Nilesh. Right. So most of you are right. Okay. So yes, impaired collagen synthesis is seen in scurvy. Scurvy is a condition which is due to vitamin C deficiency. And we know vitamin C plays a very important role in the synthesis of collagen. So in vitamin C deficiency, collagen synthesis is defective. And we know collagen is the backbone of blood vessels. Bones also, a lot of collagen is there. So what will happen in scurvy? So in scurvy, because of the defective collagen, what will happen? The blood vessels are fragile. So there is bleeding from everywhere. So you get gum bleeding. Okay. You get subperiosteal hemorrhage involving the long bones. Okay. subperiosteal hemorrhage involving the long bones. Okay, so you can get swelling of the limbs. And it is such a painful condition that the child does not want to move his limbs. If you touch the limb, the child will start crying. And it is so painful, the child will not want to move his limb. You will look and think as if the child is having paralysis, but it is not paralysis. It is rather called the painful pseudo paralysis. So because of the pain, the child is not moving his limb. Okay. So painful pseudo paralysis is seen in scurvy. Okay. And in addition, you can see scorbutic rosary. Just like rickety rosary, you have, prominent costochondral junctions. Similarly, you can get scorbutic rosary, which is more sharp, angulated, and tender. So we need to know the clinical features of scurvy. The treatment, of course, is going to be vitamin C supplementation. And friends, here again, so you have to read up about all of these. Rickets, very, very important condition. Most commonly due to vitamin C, vitamin D deficiency, nutritional rickets. There are other causes also. Calcium deficiency can cause it. Phosphate deficiency can cause it. Renal rickets is there. Okay. So rickets, we are going to read up in detail. And you have to know the X-ray findings of rickets as well as scurvy. I'm sure you must have discussed in radiology as well. Otherwise, in our pediatric videos, we've discussed it in detail. So rickets, very important. Scurvy is important. Beriberi we know is due to thiamine deficiency, night blindness, vitamin A deficiency. So deficiency of micronutrients, again, also very, very important for you to remember. Okay. So moving ahead for the last question, which we'll be taking up today. So a 5-year-old male was admitted with complaints of fatigue and pain in all 4 limbs. He also had difficulty in climbing stairs. On examination, rash was found on the hands as shown in the image. What is the likely diagnosis? Is it juvenile rheumatoid arthritis? Is it juvenile dermatomyositis? Is it osteoarthritis? Or is it systemic lupus erythematosus? Yes. So Binit, Kavin, Anjana, Suraj, Paresh, Aarti, Karishma, Dream. So most of you have answered it correctly. It is juvenile dermatomyositis. And again, multiple times you've got questions in your AIMS and INI-CET pattern questions on juvenile dermatomyositis. Okay. So juvenile dermatomyositis, what is the diagnostic criteria? So basically you need to have a classical rash. Okay. So classical rash should be there. So that is usually, heliotrope rash around the eyes. Okay. So violaceous hue around the eyes is usually there. So heliotrope rash around the eyes is there. Plus Gottron papules is there. Okay. And apart from that, you need to have any 3 out of 4. So what are these? So they are, presence of symmetric proximal muscle weakness. Symmetric proximal muscle weakness. Okay. Elevated muscle enzymes. So which are the muscle enzymes we all know, like, SGOT, CPK, right? So LDH. So apart from that, changes on EMG, changes on muscle biopsy, like necrosis and inflammation. So if any of these are present, then we make a diagnosis of juvenile dermatomyositis. So these, friends, you can see is the classical Gottron papules, which are present on the knuckles and the interpharyngeal joints, okay, in the metacarpophalangeal joints. So these are the Gottron papules in juvenile dermatomyositis. So these are, friends, some very, very important topics for your upcoming exams. And we have done a quick revision and have touched almost all the important topics. So you must go through these topics before your exams. And I'm sure you're going to come out with flying colors. Just be sincere, keep working hard, put in your best. Rather, I would say put in more than your best. And if I can achieve it, I'm sure all of you can achieve it. And you have the potential. Each one of you has the potential. I've seen how wonderfully you've answered most of the questions correctly, and you're putting in so much of effort. Just be consistent, stick along, go that extra mile for the last few days, and I'm sure you're going to make it. So do let me know how you like this video, okay? And do tell me your brilliant results once you're able to make it. I'm sure you're able to do it. You will do it. And all the very best. God bless you all. Thank you.